Hi, everyone. I think some people are shuffling in now at the hour. I just want to say thank you for joining us today. I'm Jason Hutt. I'm the head of strategy and the healthcare lead at Brandpie US. And for those of you who aren't familiar with us, Brandpie is a global brand consultancy. We help leaders build brands at pivotal business moments. We work with CEOs and their teams on purpose, brand culture, digital, and go-to-market strategy to unlock growth and drive meaningful change, especially during moments of transformation such as new leadership, M&A, strategic pivots, and most relevant to our webinar today, market disruption. So it's no exaggeration to say that AI is dominating business conversations in every industry around the world today. We constantly hear about new products, new features, new buzzwords. But ultimately, AI is a tool, a very powerful tool to make work easier and outcomes more successful. In the healthcare industry, that's not simply relevant for business, but for improving human health. However, healthcare is an industry that has always had to unfortunately balance limited resources, competing priorities, and government regulation. So while this powerful technology brings great potential, there's still many challenges to overcome. And that's why we're here today. So our objective today is to peel away the hype and get practical. And we're going to focus on the lived experience of a few experts working at the front line of healthcare delivery. We'll talk about where value is actually showing up, how leaders are placing smart bets with scarce resources, and what it takes to move from pilots to performance without losing the humanity that is at the core of healthcare. So unfortunately, one of our three panelists, Jenna Lloyd, who's the Chief Marketing Officer at Simon Med, is not able to join us today because of a scheduling conflict. But we are still in very, very, very good hands with Dr. Lacy Knight, who is the System Vice President and Chief Health Informatics Officer at Piedmont Healthcare, and Sara Vaezy, who is the Chief Product and Technology Officer at Chartis. So to kick us off, I'd love for each of you to introduce yourself and your organization and start to share just a bit about the AI responsibilities you have in your current role. And we will start with Dr. Knight.
Hi, Jason. It's great to be here, and thank you for that introduction. As mentioned, I'm Dr. Lacy Knight. I trained as an emergency physician at Cook County in Chicago, and then got involved in leadership and technology activities. Subsequent to that time, I've been at Piedmont for about a little over 6 years. Piedmont's a large clinically integrated network. We have 27 hospitals, 20 acute care hospitals, nearly 4,000 members within our clinically integrated network, where the physicians partner with us on advancing quality, and we are within reach of 85% of the Georgians in the state. And I have health informatics responsibilities as well as our strategy, portfolio management, and for AI and some of our innovation work.
Great. Sarah.
Thank you, Jason. And it's great to be here. I'm Sara Vaezy. I serve as the Chief Product and Technology Officer at Chartis, which is a management consulting firm based out of Chicago. I'm about 5 months into my new role, and we're focused on tech enabling our own organization, but also the partners and clients that we work with to solve sort of the big healthcare problems together that we've all been dealing with for quite a long time, but with a really exciting and powerful new set of tooling, which is AI. I came from Providence, which is a large integrated delivery network based in the Western United States. And I was there for 10 years. I served as the Chief Digital Officer, the Chief Strategy Officer, and I spent my last year there as the Chief Transformation Officer focused on AI transformation, and in particular looking at and focused on AI transformation of the patient, consumer, and clinician experiences. So the last several years, last 3+ years, have been really exciting for those of us who have gotten a chance to be part of and to try and shape the role of AI in how it can do those things. And we'll talk a little bit about like what AI's possibilities are.
Awesome. So This is great. And again, I'm so excited to talk to you both. And I want to obviously thank everyone who's on the call with us. Um, I just want to start by sort of creating some context here. So, a few years ago, the movie Everything Everywhere All at Once was released. And when I think about AI, it's probably the best way I can describe it, right? That's what it's felt like to me. It's promising, it's terrifying, it's exciting, it's 100 other things, right, all at the same time. So before we get down the road into sort of use cases and getting our hands dirty, I'd love just to calibrate, how each of you think about it in your day to day, right? So Sarah, you talked about spending 5 years as a consultant at Chartis, and then all those years at Providence in strategy, digital innovation in the early days of AI transformation. So given that experience and now this sheer volume of, like you said, new tools and solutions coming to market, what does this moment feel like for you?
Well, everything everywhere all at once is a really good way to describe it. And sometimes I'm tempted to be like that scene for folks who've seen it, the little rock that sits there and just kind of looks out on the view, because it can be a bit overwhelming in just its sheer volume. And how do you actually make decisions, and how do you decide, how do you discern signal from noise, and if you do make a decision, how do you make sure that that decision is safe over the fullness of time and actually adding value and not just adding expense and all these things. So it's a bit of a everything everywhere all at once is very appropriate. And I think one of the ways that we've managed and I've managed to make sense of it all is not to make it about technology. Make it more of a question about what we're trying to solve for, what operating challenges are we trying to solve for, what clinical challenges are we trying to solve for, what financial challenges are we trying to solve for, and do that in the broader context in partnership with folks who really know what they're doing, right? I'm not a clinician, but Dr. Knight's a clinician. He really knows what emergency medicine cares about and what they're dealing with, right? Like a patient shows up, you've never seen this patient, you have 3 minutes to stabilize and save their life. Well, what are the possibilities of AI in that context? You put it into a broader context, like that is a lot of don't make it a technology kind of decision or question. And then you can start to say, and then you can make it into more of like a capability oriented sort of like break it down right from there. And what we used to say is there's, sort of AI is good at doing dull, difficult, dirty, and dangerous tasks. Like those are the 4 Ds. And then there's 5 As. And the way it can do those things is in 5 different ways. It can assist, meaning it can just help out, like ride along, help out, things like in the context of healthcare, for instance, like summarize a chart, right? Just pure summarization. It can augment, meaning it can assist, but then bring in new information. So bring in outside information, add more to the equation, and be more helpful by bringing in additional information. It can automate. Automation is a big topic of conversation. That's where a lot of like workforce questions become really meaningful. And then you start to get into like agentic questions, which I know we'll talk about a little bit. Um, you can start talking about amplification. So, in the context of brand and marketing, for instance, like you could pinpoint a handful of individuals, and then in a personalized way with really efficient dollars, you could just amplify your message exclusively to them through the power of AI. And you can accelerate. We're seeing a lot of acceleration in drug delivery and pardon me, drug discovery and those types of things. So, but again, all of these are in a broader context. It's not a technology only context. It is an operating and a strategic and a, clinical and business context. So, um, that's at its fundamental level, like how how we think about it, and then you can start to prioritize and say, well, which one of those really matter? And for Providence, where I was, it was really about experience. because we had a lot of signals from our people, like our own workforce, that they needed help. They were burdened, they were just overwhelmed with information and work, and they couldn't possibly deliver the type of care that they wanted to and to their standards with the amount of burden that was being placed upon them. And the systems are broken, right? So patient experience isn't great. It's very fragmented. Access is really bad. There's all these challenges. So that's how those categories rose to the top for us.
Awesome. And Dr. Knight, obviously you were an emergency physician who, as you described in your introduction, got more and more digital and IT leadership experience as data and technology became more and more important to healthcare. So now AI arrives on the scene. What has this been like from your perspective?
So I have been thinking about this and listening to Sara's comments on this, and which I think you just captured so much of this beautifully. Um, I find it to be the most exciting and the most frightening thing I've ever done. And I think the part about it is that the generative AI creates such a great experience for the user. Like for the user, the experience is so great that sometimes you want to overlook the mistakes, you want to overlook when it's wrong. You are willing to tolerate that it'll keep getting better over time. There's just so many other things that I think we would not have the patience for if the experience wasn't so great for the user, not necessarily for the recipient or the customer. What's exciting to me is that you start to feel like there's potential to do things that you could never imagine having done before. And in some small cases, you can realize that. In some large cases, you can realize that. The part that's frightening to me is that it's predictably wrong in unpredictable ways, I think, for a lot of this. And that I think that the only way that I think we can be really comfortable with it is really if everyone becomes experts at the tools and knows where to push the limits and understand where it might falter. Because I think you move from that um, all glowy, exciting, feeling about the experience to one where I know it can help me with this. I know it might be able to help me with this, and if it doesn't, I'm okay to experiment with it. And I know I cannot trust it for certain types of things, so I will have to rely on my own knowledge set and suspicion to validate it. Those are things that I think those of us who've been around a little bit longer have um, maybe are sometimes a little bit more suspicious of everything working out perfectly in spite of best laid plans. Um, and those that may be a little bit newer and maybe digital natives may inherently trust those systems designed by folks like us, um, more than I might be comfortable. But um, in all told, there are all these just like dualities of this work. There's also the have and have not situation. So Providence, gigantic health system, Piedmont, a large health system. And while we look for offsetting the costs, we still have the ability to invest in things that we think will prove value over the long term. And smaller health systems cannot do that. People that have figured out how to work with AI, the gap in productivity, I think, and understanding is just going to really, really expand. Um, Even when I watch the stuff that's outside of healthcare, Sarah's probably in a whole new world now on the kind of independent side where the stuff that she was looking at that might have had some constraints on the health system side no longer have those types of constraints that I'm guessing she's able to push the envelope a little bit more than she could have before, thus creating further gaps. Um, since this is focused on the experience, we have been able to focus our efforts on our clinician experience and find ways that I think are very common this way, but prioritize finding ways to make life better for the clinicians. Not a lot of things have been able to do that for a long time, and now there are lots of things that can do that, which is pretty exciting. And then we've also been, I think, like many others, looking at ways that we can become more operational efficient, and then also imagining how we can leverage this type of technology to help our patients in ways that are safe and provide support and access for things that we may not have the manpower to do.
Yeah, great. So, it's interesting that you talked about those are sort of digital natives and are coming into this world a little bit later with coming with more trust in the technology. Before we move on and talking about readiness for AI transformation, I'm just curious, you both have come through digital transformation and some healthcare organizations are probably still trying to transform. Like you said, the haves and the have-nots, the smaller organizations versus the larger ones. Is there any like key nugget that you feel like carries forward from from the experience you had in adopting and bringing these new tools or making healthcare more digital? Either of you who want to if you want to jump in, if is there anything that comes to mind as
I
something
think
that
Sara said it. I'm sorry. I'm reading and mispronouncing your name, and I will get that right.
No
So
worries.
I think Sara touched on it, which is really about the what problem are you trying to solve and what the outcomes are. I feel like the discipline around that helps because you can find lots of reasons not to try to move forward. We don't have the technical expertise to understand the algorithms. We don't have um, the guidelines around that. But if you kind of anchor yourself in what the outcome is, so for an ambient listening tool has been the big thing
Yep.
for most health systems, it's very easy. We're just trying to make it easier for the physicians to document the visit with the patient and give them an opportunity to have eye contact and direct interactions so that patients feel better about the visit. There's no productivity tied to that. There are no expectations tied to that. It's really just about creating a better relationship or connection between two people by removing something. You can measure it for the patients and from the providers. And if that's the outcome you're focused on and it's meaningful, it's very easy to go for. If you are focused really on in that same scenario, we want our physicians to see 20% more patients or something like that. Uh, it's not probably the right tool to try to create more bandwidth. And maybe you're overlooking the fact that the whole point of that physician-patient interaction is the relationship built on trust between the patient and their provider so that they can provide great care over the long term.
sorry,
One other
anything
thing,
to
Dr. Knight referenced this in his earlier comments is um, going really deep on these problems. Like you got to get your hands dirty on these problems in order to and utilize the tooling in the context of the problem, but with the process and the people as part of the whole equation, right? It's not just about the tool. It's not just about process redesign. It's not just about reskilling. You got to get your hands dirty, like with the old adage of people, process, and technology, um, around the problem you're trying to solve, in order to really get something meaningful done. And you're going to uncover a lot. I think Dr. Knight also referenced this. Like these systems are what we would call non-deterministic, meaning an input in isn't going to get you the exact same input or output every single time, right? Like in a standard deterministic system, input if then, right? It's like it's a very predictable output based on the input. In a non-deterministic system, it's going to behave differently every time to some extent. Now you can put guardrails around it, but especially like as we get into more and more complex systems, it gets harder and harder to predict, and sometimes they do wacky things. And so you're going to uncover all sorts of unknowns that you couldn't have even predicted, and therefore you really got to get your hands dirty and start playing with things and have people experience it for themselves and understand, okay, well, when I try to do XYZ, what does that mean? And and that's really critical in these non-deterministic systems. And when you have like an agent doing a whole part of the workflow for you, well, what do you actually need to be evaluating yourself versus letting the agent take it over, right? And there's the whole verification piece that Dr. Knight talked about. So like the whole schema changes. It's not just put in a technology and then you're good. Like it's not an an electronic medical record, where it's a system of record with really, standard operating procedures and standardized workflows. It's a very different type of technology.
Great.
So I have a question actually, Jason. Have you implemented anything related to this generative AI where you didn't find on the other side that you didn't quite know all the things that you thought you knew before you started?
Mhm.
Oh yeah.
Yeah.
We had a very interesting example from Providence, actually, that came about in the context of patient navigation. And the example was, I'll give you all a very specific scenario, which is what we wanted to do was support patients so that they didn't have to send an in-basket message for everything. It helped our physicians because it took some of the in-basket messages out of their, from their queue, and it helped our patients get, sort of real-time responses in the form of not just a chatbot, but also in the form of like live messaging or a live, sort of back and forth message experience. And we had several use cases. One of them happened to be medication refill. And that medication refill use case had very rigorous guardrails around it that said it was only supposed to be answering questions that where there was so nothing clinical, where there was already a refill in the order and just basically the fulfillment piece of it. And in two instances where patients were asking questions about their refill, they asked something about like, it was something along the lines of like, should I keep taking this medicine? And the response was, take your medication as prescribed, which sounds relatively harmless, but is
Mhm.
technically a clinical
Mhm.
response. And from there, you don't really know what's going to happen. Now, in both of those cases, we had a monitoring framework in place. It actually got flagged. We were able to hit a kill switch and do a whole set of interventions, but that was not predicted behavior. It doesn't sound that dramatic, but it was not predicted behavior. And it happened twice in millions of conversations, but it still happened. And one can anticipate a scenario in which there are more significant things that happen that might, trigger actions or consequences that are, that are more consequential than something like that. So, those, we never anticipated that something like that would occur.
Yeah. And to answer your question, Dr. Knight, right, when I ask a question about something, it's certainly not as important to health and wellness as when your clients or your patients, your customers do that kind of thing. So I want to move forward just a little bit. And Sarah, at the beginning, you talked about there's so much noise and trying to separate signal from noise. I'd love to spend a few minutes talking about how both of you, and we'll start with you, Dr. Knight, how you diagnose really, where to focus, right? There's so much out there, and there's so much from industry now coming in with solutions. They're tech native, so they've got a problem, they've got an answer to your problem, right? And they're sure it's going to solve all your problems. So I'd love to know, Dr. Knight, what's your process for identifying sort of the first priorities inside care delivery and operations, and where to direct energy with an AI solution?
I will answer this to the best of my ability, but this is one area that has gotten very, very difficult because I don't know when it was, but maybe a few years ago, to develop a product, you needed to hire a lot of expertise, you needed a lot of money, you need a lot of time, or you need to have the expertise yourself. And now, you can develop solutions in a few weeks without really having expertise in it. That's a minimum viable product and things like that. So where we have approached it is we try to do some industry surveillance in and outside of healthcare. So we just have some idea of how people are using AI to solve problems. I have different teams that are connected to different entities in the organization, different roles in the organization that are I like to think of these roles as almost moles within other organizations, just where they're listening to where there are operational problems And then we take all of that stuff and then we do some framing of where we find that in general, we have an opportunity to be closer to a fast follower. So things that where we're relying upon taking lessons from others that have gone before us and then applying those insights into our deployment as a way of kind of minimizing the risk, I would say. And then I also have some insight into the leaders and organizations within Piedmont that are a little bit more flexible and tolerant of things not going perfectly well and are very much looking for solutions. So we've got different groups that are very good partners for things. And so between the industry trends where we kind of pick things that rise to the top as key themes we want to go for, between internal stakeholders that may be more amenable to the messiness that comes with this, that's how we pick in large. And then I have, I think like everybody, a steady stream of startups and different companies that potentially sound interesting. And at first pass, I'm trying to check to see if they solve something I know is a big problem. And if they don't, we don't really spend a lot of time talking to them. I may refer them to one of my peers that has some need. And then the second question is if even if they solve that problem, how feasible is it for me to get all of the resources, both on the IT side and the operational and the clinical side, together in consideration of every other strategic non-technology initiative, um, to try to make something work. And if the timing's not right, then again we have to pass. So it's a bit of a dance that's orchestrated with a lot of help across multiple teams, and then we have a governance layer where we will start to present these ideas. Hey, we think this might help us. This might be the way it helps us, and then we get some input from a broader group of senior leaders to decide where we start to test.
Yeah. And so, Sarah, before you answer that, I would love to get it now from your new vantage point, right? To understand not from the system perspective, but what problems are showing up for you most consistently across sort of Chartis's clients or within Chartis, and how is that shaping where you guys are focusing your energy and your investments in terms of what you are building to serve the needs of health systems like, Piedmont?
Yeah, I'll give you kind of two answers. I'll give you the domains where we're seeing a lot of potential, and then I'll also give you sort of the initial answer, which is like, how do you suss out signal from noise? And I'll give you the which is the because I'm not going to build everything, right? Like there's no reason to build everything, even though there is a maybe for a small soapbox moment, which is that one of the challenges that we now have that is because it's so easy, as Dr. Knight has articulated, to build with all the tooling, folks are tempted to build everything. We shouldn't all build everything. So I'm never going to build everything. So we still all have to partner and find other companies to work with. So the domains where there's a lot of potential to apply AI are where there is a lot of structured data, where you can utilize that structured data and put it in the context of even activity. So linking together like activity and outcome is like that's the holy grail, right? We've never really been able to do that, but I think that there is now the potential to be able to do that much more than we were historically. So think like access. How do you actually match supply and demand? How do you actually measure throughput and be able to connect the dots, not around throughput within the context of a very narrow department, but like looking at it in a much broader context. Those are some of the domains that we're looking at, but it ultimately comes down to like intelligence. It's not just about uh, being able to analyze data or find patterns. It's actually about like being able to apply prediction. So, just in analytics, for instance, there was a lot of prescriptive analytics, and now we're doing predictive and, sorry, descriptive analytics, and now we're doing a lot of prescriptive and predictive analytics. So like we're shifting the discussion much more to like scenario planning, prescriptive, forward-looking types of things in these domains, like where there's structured data, where there's the ability to find patterns and then forecast them out. So revenue cycle is another really great domain. And then the way that you need to look at te specific technologies, I always say like the biggest differentiator is and separating out signal from noise is does it work in real life? And how do you suss out whether it works in real life is actually evaluation. So knowing how to monitor a solution and being able to test like and test whether that like asking folks questions about how do they monitor their solution. And when I build something, I really think about monitoring. Like, how do we ensure performance, not just at a snapshot in time, but on an ongoing basis and what we would call like runtime. Things have to, work 24 by 7, 365. It's not just when you install it and flip the switch on. It's all the time, and it needs to be getting better all the time, by the way. So your evaluation methods are in fact one of the biggest ways by which you can separate out signal from noise now. And so, questions for folks to ask companies that they're going to work with is, are you using like LLM as a judge, meaning actually using large language models to evaluate other large language models and building a test for how would you do that? So those are the types of things that you can do to actually, once you've identified the problem you're trying to solve, once you've identified a set of companies that might be doing that, then you can apply these specific questions to actually get down to like the separating out the wheat from the chaff.
Yeah, and I was just going to follow up with that because both of you talked about people, process, and technology. Before we move into sort of where you sort of start to place the bets, I'd love to just one last question about sort of readiness. And Dr. Knight, you mentioned that there's got to be the right place or fit within the organization, not just a need. So I'm curious to hear from your perspective, and also, of course, from yours, Sara, where you're seeing easier traction? Is it with clinicians? Is it with non-clinicians? Obviously you're a clinician yourself, Dr. Knight. And then as a follow-up to that is, how are sort of leadership roles and traditional organizational hierarchies changing within these health systems, right? Where AI and tech and data has such a power. Are you seeing new roles, new people coming in, outside of healthcare, outside of traditional pathways, to take on these roles within their organizations? Dr. Knight, you can start.
Um, so on the first part around, I'm trying to make sure I have the question clear. If you could maybe just repeat the first
Yeah, yeah,
part.
yeah. The first part is just really, from you're now sort of wearing both hats as a clinician and a technologist. I'm curious, are you seeing the clinicians in your health system
How
more
are
or
we
less
finding
well?
people?
What's that?
Yes, I gotcha. So it's maybe part of the reason why sometimes health systems I think can be hard is because we are oriented to be perfect. So you have a bunch of clinicians that really have to have, high performance and grades. You've got about a bunch of administrative professionals that are just used to their work product being as close to perfection as possible. And then the impacts of their clinical work really impacts patients when it doesn't go as well as possible. And so you're trying to ask them to try tools that you're not totally sure how they're going to work, if they're going to work, or how they're going to go wrong, and just give you feedback along the way. So I would say broadly speaking, we have large groups that are really not interested in that experiential work, but we have a continuous improvement culture around quality that I think is common within health systems. So even as good as any one health system is, every all of us believe we can get better. And I think the excitement about these types of tools is that there is some path to get better. When it comes down to Finding people willing to engage, it just depends on what feedback that we want. So in some cases, the feedback might not require someone who is less likely to adopt something, but in other cases it will. So for example, one of the tools that many have tried, we have as well, is related to the in-basket messaging responses. That's something that isn't a great tool unless the people that are most particular around the quality of their messages are the ones that believe that this is actually a good tool. So for us, that has meant really an extended and very challenging testing cycle because the product, when it first came out, was not anywhere close to as good as was necessary to instill confidence amongst the most particular users. But that's the right population, and that's the right place for the iteration in order for us to have something that's meaningful to scale. So again, it's the problem Sara mentioned. It's the processes. We do have to find people that again are willing to. This is all. I tend to call this work heroic effort. Everyone is staffed and time is allocated to doing everything but this new work. So in order to pull this off, even testing and scaling, you need people that are willing to take effort and time they don't have to help see if the promise of the future can be fulfilled. So it's not for everybody. But I think fortunately, once you get a program started, people do come out of the woodwork where they want to help, they want to be involved, they want you to help their idea. And if their idea doesn't necessarily have merit, but they have interest, I think we can shape and develop folks to help us with the things that may be prioritized. Um, so I hope that's the right way to respond to the question that
Oh,
you'd
that was
had
great.
on the front end.
Sorry, did you want to add anything before we move on?
I think the heroic effort piece is so interesting and it's absolutely true. And things are so broken that folks are willing to put in heroic effort. And you're seeing um, a lot of organic places where folks who are tremendously busy and have way more than enough on their plates are willing to learn new things and engage with new tools just from the ground up to be to um, uh, in order to kind of mix it up and change the way things are done. There are a couple really good examples, like on the clinician side, open evidence, which has been around for about 2 years now, is a really good example. I mean, they have, I think it's about 40% of registered, licensed physicians in the United States are using open evidence after 2 years. That is astronomical growth. And they know that because you actually need your NPI to utilize open evidence. So they've got, they know who's using it. And it was a purely, just sort of organic effort. Like they didn't necessarily do a hard marketing push. And what they're doing is connecting into, I believe it's the New England Journal of Medicine and curating the content based on the searches that physicians are doing for the specific clinical questions that they have at the point of care. For like sort of unique clinical decision support sort of use cases. So that's one example. And then on the consumer and patient side, I mean, there are more, it's about, I think it's like a quarter of all chat GPT related conversations are health related. I think it's like 40 million unique people per day are using chat GPT for health related conversations. It's not 40 million queries it's like, or conversation, 40 million people every single day. And that is a huge number when you think about it. Now, the revenue numbers and all these other things will follow over time, but we're seeing a lot of just like organic groundswell because of a lot of hard work has been done over time. A lot of the distribution challenges of getting technology in the hands of folks have been sort of that work has been done, and folks are willing to pay for these things. So, everybody out there pretty much pays on a recurring basis for some sort of software. Like from a consumer perspective, on a monthly basis, you pay for Netflix or, whatever else. And so, why not just pay $20 a month for your healthcare too, if you're going to query it? And so, like, these types of barriers have started to break down, and we're seeing a lot more like organic adoption. And that's likely going to continue to grow, that sort of organic uptick, because the systemic nature hasn't quite caught up yet.
Yeah. It's also super interesting to hear you talk about, Dr. Knight, you talked about being a fast follower and having sort of, ears to the ground. One of the favorite quotes I had from a previous client was they said, I was trying to say, oh, it's so great, you guys are a trailblazer. You're gonna do the first of things in your industry. And he says, well, we'd love to be the second. There's a lot of pressure and stress and investment and headaches that go along with being the first. So I'd love to hear now, once you sort of start to understand where there might be value to be had, how you decide to get there, right? Whether it's, you talked about it just only takes a couple weeks to get to an MVP now. But when you're thinking about some sort of transformative projects within your health system, whether to build, to buy, or to partner, especially right when you're being sold by myriad vendors who claim to offer, great big solutions. So I'd love just to hear a little bit, Dr. Knight, how you go about that process. Once you've heard, whether you've identified a challenge or you've heard about an opportunity or a new technology, how you make it work for your system.
Well, there's a lot of estimation. So the our process is we look at a lot of things that sound interesting are in part based on um, users. So I mentioned the existing users, so we can reference someone that is typically large, complex place like us because we have similar DNA, I would say. And then once we find that it feels like there should be something that's useful, we may be able to get some reference discussions with someone. Then we assess the feasibility. Do we have the technical skill set and infrastructure to be able to support what that looks like? We connect with the operational or clinical leaders to understand whether or not the problems that are solved are significant enough here um, that merit solving. And then we always anchor these in a pretty strict business case ROI. It's not always a financial ROI, but if we've got the right clinicians and clinical teams or even back office and administrative functions that have an interest and agree that the problem's there, can we put together a business case that clearly defines a minimum level of benefit to make it worthwhile? And if we won't go to something super detailed up front, we'll get to at a very high level. I really call it a high level ROI. If we bring in ambient listening, and the physicians use it, they will be able to draft their notes faster. The patients will be happy with it, and then we bring that to our committee to just talk through it. Does this seem like this is valuable for the health system broadly? Because we have maybe a unique lens where we are not looking to just test a lot of things and have small benefits in pockets. We are looking to take things that by the way we're organized and structured, we have the ability to implement something at scale very quickly and achieve very large benefits from doing so. So when we're looking at an ambient solution, we're not looking one that may be best of breed for primary care or specialty. We're trying to find something that can solve problems across the lane. And then build the ROI case, and then most cases we are doing some sort of a pilot project, might require some investment up front. And that's where the rigor comes to figuring out what it would take to be successful. And that means that most things we go put through this level of rigor are successful. Some things are not quite as successful as we would like, and we end up kind of limiting time spent on those types of things. But that's kind of our process end to end.
Mhm.
A lot of rigor, but still a lot of optimism, I would say, throughout the process that these things are going to come together.
And Sarah, from your perspective, obviously you're now in charge of sort of productization and scaling solutions. How are you going about, your job and thinking about, who to partner with? Obviously, you also have the opportunity to acquire and bring in capabilities that could become, Chartis solutions.
We spend a lot of time thinking about what's the right thing for us to own, and then what's the right thing for us to partner with folks on. And there is a lot of uh, there are a lot of great companies out there doing really important work, I believe, in sort of unique, like point solutions or in unique verticals, and where companies like Chartis can be um, especially helpful and valuable are in sort of the integration, convening, connecting the dots, and the overall intelligence space. So often, like what we've struggled with in healthcare writ large has been in a lot of like I don't want to say interoperability because we're not going to be an interoperability company, right? But in the reducing the fragmentation, connecting the dots, ensuring that data flows, ensuring that there's continuity for the patient experience, ensuring that physicians aren't constantly, having to look at different panes of glass. There's like all of that siloing, and siloing in terms of data, experience, and intelligence is what we can help overcome. And that's where we want to be building, right? Building the knowledge layers, the intelligence platforms to support that continuity. That's what we want to really double down on. And everything else is working with partners who are sort of amenable to that vision, where they have a really great niche that they focus on. And and because of that, like there's a lot of room out there for all sorts of folks, right? And even in the world of, for instance, like there's more than one ambient listening company out there. I think that even in those worlds, there's room for more than one. And it's because they all come at these problems from different lenses and solving the problem in different ways. One comes at it from a real doctor experience, lens. One comes at it from a coding first sort of specialty lens. Like there are so many sub markets and so many sub problems to solve. I think there's plenty of there's a lot of opportunity out there, but there needs to be sort of this like orchestrator, intelligence layer kind of approach out there, or else we're going to kind of repeat the sins of the past where we continue to have this fragmentation and siloing go on.
It's so interesting because I love, Dr. Knight, how you talked about that literally like every minute of every employee's day is scheduled and accounted for, and trying to figure out where do you test and scale is just sort of time on top of that. So I'd love to just spend a couple minutes, but we only have about 10 minutes left. But when you do have a successful pilot, right, and you need to scale it, and as you said, Dr. Knight, create performance across a whole system to really receive the benefit that you'd intended. Um, what are some of the things that are most important for the organization to get right? You talked about having a culture and a commitment to the mission, but what are some of the other things that sort of people on this call could be looking out for as they try to scale?
I think I think the language that I use around this is maybe what's the first problem? Because I do think that when you find a right solution or a good partner, your inclination is to expand with their capabilities And that makes for a very difficult pilot and kind of value case demonstration. And so I think we've been applied a very particular level of discipline on this is the reason um, we're choosing this use case or these sets of use cases with this partner um, to test its viability. That's the testing part. We are pretty prescriptive on trying to minimize the scope and identify the scope up front. In concept, though, we're not looking for partners that just do one thing. So I think, the approach we're taking is trying to find platforms that can support our needs today and platforms that can grow with us. We're just picking something limited to test with. So I do think that approach is probably very important that you always take a long game approach for these types of decisions and recognize that there are things you're just not going to know. And so you want to try to figure out the people that can accommodate your changes and whose changes you can accommodate along the timeline, but then be very, very precise around what you want to experiment with and select something that is narrow in scope but high value in its outcome.
Yeah. And Sarah, what do you feel are some of the secrets to success for sort of 0 day readiness, which I know is something you're really passionate about, but as Dr. Knight said, really being able to see that ROI.
Um, I think the number one thing, maybe there's two things actually. One, clarity around at least what you're trying to solve for. If you don't have that, it's you're sort of going to be really hamstrung going into it. And and by the way, that may evolve over time, and that's perfectly fine, but at least some sort of hypothesis around like the problem versus like we're trying to like force fit a solution that we don't really understand into a problem we don't really understand or didn't bother to even like examine. That's bad. That don't start there, right? That's number one. And then I think with especially if it's like a bigger like AI transformation is not for the faint-hearted and it's also not for it is not again, it's not just like a substitutive technology only kind of endeavor. It is a organizational it's an organizational transformation, and without the CEO being not just bought in, but like driving it, it is really I would maybe go so far as to say it's doomed to fail. And uh, it is so um, it is so foundational to the way that everything will ultimately get done. Now, where we've been so far, for instance, with like I mean, ambient assistance, right? And those have been largely, I would say, substitutive activities to date, right? We're arming our clinicians with a tool that helps them have better quality of life, be able to do documentation in a more timely fashion, and with less burden. But it's not completely redesigning the workflow or completely supporting them in helping them do team-based care differently and arming them with tools. It's another tool in their tool belt, and it can help with a lot of things. But it's and so and by the way, the research shows and that there's relatively little ROI that is coming from that outside of wellness, which if you're like a super hard-nosed CFO, you're like, well, does wellness pay the bills? And some would argue yes, because your physicians don't burn out, they don't leave. You have much better retention. You have like there is a long tail there, but if you're looking for an in-year ROI, you may not get it. And so you have to be more expansive in your thinking about ROI and it very quickly, I guess, is the short version. And so you have to have your CEO behind you, regardless, whether it's small or big. These are big transformational things, and you got to push it. Um, And so that would be like the second thing. Have at least some understanding of the problem you're trying to solve. Don't just try to cram a solution in there and have your CEO behind it.
Awesome. So we only have a few more minutes left, and I really, we started off this webinar talking about how it feels, right? You both have obviously sort of seen this. It's like the boiling frog. It's you've been working in digital, you've been working in IT, so this is sort of the next step. And for a lot of people, maybe who haven't been working in that world, it feels kind of everything, all at once. I'd just love to end, with your sort of foresight, what you're looking forward to. There's a lot that's come on in the market. Like there's a lot of change and transformation, and there's obviously a tremendous amount of opportunity to look forward to. So to end on an optimistic note, I'd love just to hear either, where you're sort of seeing the biggest difference so far, or where you feel like we're going to see the greatest amount of impact in the next, 6 months, 6 to 12 months.
Well, I'll let Sarah take the last word, but so for me, the one thing that's really exciting about this is that you cannot take advantage of these tools without changing something.
Mm.
So we've talked a lot about ambient, for example, but it does mean to make ambient work, Jason, I have to tell you what's happening to you. I have to explain things to you that maybe I didn't really explain. I have to talk and engage with you in a different way, and that's why the patients benefit from this. And so there's this tension that these types of tools create, where I have to choose. Do I want to interact with a chat function to get feedback that might be helpful and do this iteration in order to get value or not, just as an example? And so I think when we start to get really good at finding specific sections where these tools have a great impact, it's going to push us to rethink how we care for people.
Right.
And we need to rethink how we care for people in order to enhance these care models. But I don't know that we had a great reason to do so, because they're mostly working the way that we want them to work. Now that we're overburdened with so many things and we want a new future, we have to challenge that. So I'll hand it off to Sarah.
I love that. The way you just explained that was so beautiful. I'm I am optimistic that in the near term, like there are just like it's sort of like the more you know, right? Like the more um insight that's released may help us actually transform some operations. And I think about it, for instance, in the context of like access and supply and demand matching. We've struggled in for so many years on primary care access and just, it being so capacity constrained. And not just because we don't have enough physicians, which is definitely an issue, and because patients don't get the right care at the right time. So they might go to a clinician that didn't meet their needs. So then they have to go to another clinician, and we're consuming capacity that we shouldn't have consumed or whatever, like all of these sort of very cold terms. But actually being able to match the right patient to the care that they need, and matches to their intent, their preference, their motivation. I think that's very much in the near term on the horizon and doesn't require really rigid ways that we've done this in the past. And I think we could be doing that in like the next 6 months. Now it's going to require a lot of other changes, as Dr. Knight has said, but I'm very excited. The tech has been more challenging in the past, but I think we're on the horizon of a breakthrough there.
That's a great place to end. So I want to obviously thank you, Sara, and Dr. Knight. Just incredible for sharing your time and your experience. And thanks to everyone for joining and listening in. Obviously, hope this conversation has been beneficial, and that it provides people with a clearer path forward. As you both said, one that leads to better care, better operations, and a better experience for all of the incredible people who work at the center of this incredible and critical system, right? So thank you very much to you, and obviously good luck to both of you in the near future.
Thank you.
Thank you.
All right, thanks, guys.